Dear all, I hope you can hear me. My name is Ula Valverde. I work since 2009 with Drug for Neglected Diseases Initiative, working on developing drugs for human African trypanosomiasis. I have been involved in clinical trials on NECT, on melarsoprol. On NECT, on fexinidazole, and on acoziborol, which is now in development. I am very, very pleased to introduce to you this session of today because I have the feeling that very often we concentrate on physical tools like drugs or diagnostics, which was the subject of the meeting yesterday, of the roundtable yesterday. But this has a different perspective because we are bringing the voices of the people suffering from the disease to the front. And we have a great panel. And I am very interested in listening what they have to say. Thank you for participating in this very interesting roundtable. And I pass now the word to Jennifer Palmer, who will introduce the roundtable and the subject. Thank you very much and welcome.
Thanks, Olaf, and welcome everybody who has come to the second roundtable in this nice series. I am going to share my screen. I'm hosting this roundtable today. I'm also a social scientist that works in the sleeping sickness field, and it is really nice, as Olaf said, to be able to focus on issues that are often grouped into the expertise and interests of social scientists. But of course, it's not only social scientists that are interested in these things, it's everyone who works in HAT programs in terms of wanting to know how systems can be improved to be able for programs to work to find all the remaining cases and achieve our targets. So thanks everybody for joining. We have three amazing panelists for you today, all social scientists. And I'm sorry that Katian, who also works in sleeping sickness in the Congo, is unable to join us today. With us is Salome Bukachi and Charlie Kabanga, and they have worked in East and Central Africa for many, many years, both on a variety of diseases, and particularly recently on sleeping sickness. Charlie has been involved in a large program in the Congo, studying community engagement in sleeping sickness. And Salome has been working in a number of countries, Uganda, Tanzania, and Kenya, on both Gambian Rhodesian and SEHAT over a number of years. And then we have Anne Kelly, who is a social scientist and anthropologist who has worked for a number of years on malaria, on Ebola, and on cutaneous leishmaniasis, and also has supported my own work on sleeping sickness in South Sudan over the years. And you'll be able to see in the chat a much fuller biography of each person that is joining us today. Now, the chairs, all of the chairs of these roundtables have been tasked with summarizing very quickly some of the key themes amongst work that has been pre-submitted to this workshop according to the themes of the roundtable. In this case, we had around 10 video abstracts and some additional paper abstracts. And I've picked out two that are particularly relevant to our roundtable today. The first is by a team and author list led by Charlie Kabanga, who's on the panel. And she conducted this study of community knowledge of sleeping sickness in, I think, 6 provinces of the Congo. And if you haven't listened or watched her video abstract, I would really encourage you to, because she provides a very moving story an ethnographic sketch of a man who has died of sleeping sickness, told by his wife, his widow. And she comments that stories of deaths from sleeping sickness or HAT in the Congo are indeed now becoming rarer, now that we have moved into an elimination era. But these stories, in all of their moving detail, really reveal deep community knowledge of the disease that has persisted over a long time. But she cautions us that knowledge of sleeping sickness amongst communities is heterogeneous, and especially in young people, it is more limited. Young people know less about sleeping sickness because they've been less exposed. In general, there is also less knowledge of the new tests and treatments that have entered the HAT field in the last decade. And HAT knowledge is also affected by traditional beliefs, including the idea that it could be transmitted by spirits or witchcraft. When she asked people what their role in sleeping sickness should be, it was mostly around environmental clearing of tsetse habitat and less about setting traps and less about participating in the kinds of health services that we organize for case detection and treatment. And some of her recommendations were, I think, really quite novel for the field of sleeping sickness. And it's gathering momentum as we have more social scientists entering the field and studying how programs should be engaged. And this involves making sure that programs really support an empowering approach to community engagement, as well as a holistic approach to management of individual cases that address both medical and psychosocial needs of people with the disease. And I'll let her discuss more about her findings in the panel today. I'll also give you a sort of synopsis of another paper by Jean-Benoit Feliz and his team, which I was also a part of. And we looked at the idea that the last mile of elimination of sleeping sickness will inevitably hinge on the labor of frontline health workers. And an important part of this labor is the tacit knowledge that frontline health workers can draw on to do their work. And by tacit knowledge, we mean very practical experience of sleeping sickness. So that marriage between theory and experience or practice and how that comes together to do work with this rare disease. And we compared experiences of frontline health workers in sleeping sickness programs in two countries, Congo and South Sudan. And we found that big differences in the ways that these programs have been funded over the years have really affected the careers that health workers have in sleeping sickness, and in turn, opportunities for them to gain practical experience of sleeping sickness that they can then deploy in elimination efforts. And we concluded that integration of sleeping sickness services into national health systems is a really central issue that lots of frontline health workers are concerned with. And particularly, they are interested in how these changes towards integration affects the acquisition of tacit knowledge or practical experience. And we recommended that we need to both extend expert training in sleeping sickness to more health workers, at the same time as that we simultaneously value and reinforce expert knowledge networks and hubs, for example, at referral centers and treatment centers. And we highlighted that frontline health workers are very worried that dismantling existing structures, human resources structures that help run sleeping sickness programs, they risk, if you dismantle those structures for learning, this also risks knowledge generation that we need in going forward to elimination. And finally, I wanted to draw everyone's attention to a very new publication published this month by authors at the WHO on the progress that we have achieved in the roadmap for HAT, or sleeping sickness. And they point out that we have largely reached the year 2020 elimination goals, which is to reduce the continental caseload between 2,000 cases per year, and to dramatically reduce the geographic areas at high or moderate risk of disease. So it's almost been achieved, that second point. And 2 countries have been validated as achieving elimination as a public health problem. Additionally, they point out that the capabilities of health facilities across endemic areas to offer passive detection and treatment services has been steadily expanding. And active case detection through active screening has been maintained over the last decade. In 2019, 2.8 million people were screened for sleeping sickness, and this was slightly reduced in 2020, largely due to COVID-19. But they also point out some important challenges for the elimination of Gambiense HAT transmission by the year 2030, which is the second goal in the roadmap. They point out that one of the main issues is potentially cryptic reservoirs of infection in both humans and animals. And they point to this concept of integration of HAT surveillance and control into national health systems, one of the issues that we raised in Jean-Benoit's paper. They also are pointed to challenges in making sure that skilled healthcare workers are available and keep being trained, and that more effective and adapted tools need to be developed and deployed, and skills around those maintained, and that we need to continually keep an eye on funding and coordination of elimination to keep energy up. So if we think about these sort of 3 pieces of research and how this can set up our panel today, if we can kind of start off by thinking about, first of all, the concept of targets and roadmaps, and then drawing on Charlie's work, thinking about engagement with communities, and drawing on Jean-Benoit's work, which is looking at healthcare resources, how we should be viewing health workers and the needs that they have. So I will turn it over to the panelists now, who I would encourage you to turn on your cameras and microphones. And I'd like to hear from everyone. So your opinions on the first question. Now, this is around the idea that setting targets and setting out a roadmap has the very important effect of focusing minds on a collective task. But setting a target also has potentially unexpected or unforeseen dynamics on relationships between different types of health workers, how surveillance information gets passed up and down between communities and donors. So I would like to ask your thoughts on these concepts. What are your hopes associated with having targets and a roadmap in place for sleeping sickness elimination? And is there anything that worries you about having numeric targets guide sleeping sickness work? So I will stop sharing my screen so that we can see everybody's faces, and I will try and copy and paste. Oh no, I don't think I can copy and paste into that, but hopefully all the panelists have my slides as well. Perhaps we can start off with Anne, if you have any thoughts on the first question.
Jen, I'm going to actually leave it to the other panelists because, as you know, my experience is a little bit more broad-based and less HAT-specific. I have a couple thoughts, but I'd really like to hear from them first. Thanks.
Great. Charlie or Salome?
Yeah, for me, I think having a target is really good at this time because, as you said, it's going to focus the energy, and the work will be more, the dynamics will be renewed to make sure that the elimination is achieved. However, as you said, numerical targets usually forget the actual experience of people who have been affected by this disease, the community. When a person has been treated, there are still things that they continue to experience. Stigma remains even after they have recovered completely. So even when we start talking about elimination, that person will still live with stigma, and they need to be reintegrated in a society. So we need to integrate that also in the activities that are being selected for the elimination. We need to make sure that with the elimination of the disease, we eliminate also all the social experiences, negative experience that people have to undergo because of the sleeping sickness. That's what I can say about this.
Thanks, Charlie. And I think you're absolutely right. I think a lot of the other NPD's elimination programs have done a very good job of drawing attention to the remaining chronic problems associated with the disease after treatment. I'm thinking especially of filariasis, elephantiasis, and some of the skin NPDs. But I think we have thought about that much less in the sleeping sickness field, and you're very right to point that out. Salome, do you have any comments?
Thank you, Jennifer. I'll add on to what Charlie has said, and I agree with what she has said. When I look at the aspect of setting targets in a roadmap, that is very good because that focuses then the attention, it focuses the funding towards a common goal that every discipline, every organization will work towards that focus, which is a good thing. But I think it can be improved by one of the things we need to realize is that one size does not fit all. So the methods we are going to use to focus, to reach towards a particular end, need to be customized to the different socioeconomic, cultural, political contexts, so that can then, each context can have something that is adapted to their own environment, to their own setup, but with the same targets and with the same goal. The second thing is, the second concern I would have with numbers. Numbers are good, but we need to add on other things. Just like Charlie has said, that the life of the person, when we look at numbers, we forget about the human person and the disease on this human, the human who's been affected by the disease. In one of my studies, I was looking at the socio-cultural impacts of human African trypanosomiasis. And one of the things I was bringing out is that it's not just enough for us to talk about numbers in relation to talking about the DALYs. When we talk about the DALYs as the burden of the disease, we forget about the stigma that Charlie talked about. We forget about how livelihoods are impacted on negatively. So I feel it's important that numbers are good, but it needs to be integrated with other qualitative aspects. Thank you.
Thanks.
Yeah, I'll just come in here. I mean, just to amplify those points, but also, Jen, to pick up on something you were saying just about the work and labor of those involved, the health workers who are involved in kind of meeting these targets, and how, there's so many advantages of kind of, as you say, kind of focusing and, zeroing in attention, but the kind of capacities which might help you reach those targets can become quite narrowly circumscribed. And I think, the papers you were referencing and brought a work around programs that, in addition to tackling the specific disease, actually also kind of build the capacity of these workers to address a whole other sets of community issues, can really make a difference, have cross-cutting impacts. So I think there is this balance between how much attention you have on one specific issue and how you can leverage those issues actually to enhance the capacities of those carrying that out. And I think the kind of numbers, keeping things as a number of target, might in the end have this compounding effect of reducing the kinds of skill sets that you can really seed into that labor force.
Mm-hmm. Thanks, Anne. And I think that really we've learned that across a huge number of diseases, particularly in elimination programs, both historically and in the 90s and 2000s. And certainly, I mean, sleeping sickness has its own history of elimination programs in the 1950s and 60s. But yeah, there hasn't been so much historical and social science engagement with this idea of how targets circumscribed the work that health workers were asked to do and what they weren't then able to do. We've seen, I guess, a lot of criticism of the pentamidization campaigns and the harm that injecting people with the same needle has done in Cameroon, and some of the harmful effects on having all your attention focused on a disease to the detriment of side effects of healthcare interventions as well. Thanks. Perhaps we can move on to the second question, which were about engaging communities. And the question for panelists is, what are the key things that sleeping sickness elimination programs should consider in their engagements with communities? So here, potentially talking about challenges, traps, as well as good practices that we can think about. What don't we know, and what further research may be needed or could be interesting to do in this field of engagement with communities? Mutia is our translator and has her hand up. Are you hearing us well? Okay. Would anyone like to start us off? Charlie, I know you had some really nice points in your video abstract, which I didn't present. If you'd like to start us off.
Yeah, thank you, Jennifer. I think we have reached a critical point at this time when we are all talking about elimination, and we need now to adapt our approach to elimination, especially the way we engage with communities. I understand that initially, because of the pandemic, the high prevalence of the sleeping sickness, there was a need to have a specific approach that was a top-down approach, where things were very structured, coming from the top to the community, having an approach where mobile teams will go in the community and the communities need to come and get screened and follow the treatment, etc. But now that the context has changed, there are less cases, and the community's perspective of the threats posed by this disease has also changed. So it's not like automatic now that the communities will just come and start being part of the control activities. So this tells us that it's time to change the approach. We need to have a kind of, not really an exit strategy, because I don't think that we can say that we need to stop now any control activities. We need maybe just to change the approach by giving more power to the communities. Instead of the community members being always the recipients of the control activities services, they need now to take leadership on those activities. They need to take the responsibility of the control and surveillance, because as the resources are becoming scarce, the most sustainable way of dealing with control and surveillance is the communities can now start doing the actual detection of cases and referring them to health workers. Otherwise, we'll still be in a case where many cases are just detected when they are in the second phase, because the mobile teams are no longer doing the screening as they used to do it. So the communities need to acknowledge that the sleeping sickness is still a risk for their communities, and they need to put in place strategy on how to handle that, how they can make sure that the risk is lessened. How do they mitigate the risk by putting in place activities and collaborating with the health system? And yeah, so it's also they get that ownership of the control activities. That's what I would say about the best way of doing community engagement during this time.
Thanks, Charlie. It makes a lot of sense what you've said about shifting everybody's, not just ours, not just communities, everybody's perspective on whose responsibility it is for things like case detection. And certainly in my work, I've tried to draw attention to, and I recognized it in yours as well, the existing knowledge that communities already have about the signs and symptoms of sleeping sickness and the existing practices that underlie health-seeking behavior and ways that passive case detection does happen successfully. And I think it is important to recognize that there are a huge amount of successes that are led by patients, their families, ex-patients, people who've seen other cases in the community. They are successfully leading to cases being detected and treated and saving lives. And I think one of the most important things that we can do as programs is recognize the resources that are already in communities. But you're, I think, taking this idea even further and suggesting that we need to do something more active to support these structures that already exist and could be amplified in communities to increase referrals, especially to try and make sure that those referrals are earlier to do. I don't know if you have any experience or ideas of what kinds of activities could be done to really actively support community resources and case detection. Do you have any ideas? Yeah.
When I was conducting this research, I had an opportunity to discuss with other actors who are working on neglected disease. And one of them is Save the Children. They are working on tuberculosis. So they also understood the need of having a sustainable or more empowering approach to case detection. So they tried to just support the communities first to get them to do a problem analysis regarding that disease and to identify gaps. After identifying that gaps, then came up with a strategy or an action plan on how to address those gaps. How do they identify people who in the community who are presenting early symptoms, no matter how serious they are, even just a simple cough, that's already a sign that can be associated with tuberculosis. So the community is actively identifying those cases and referring those to the health workers. And yeah, after that, then if the cases are positive, then they can be treated. But if it's just a normal cough or nothing serious, then life continues. This really helps early detection of tuberculosis, and this can lead to really elimination, especially as we know that the sleeping sickness, especially the Gabiense, it takes longer to get identified. So if early detection is done, especially also working with alternative health providers, traditional healers, church leaders, who usually receive many people who have some symptoms already. But if they delay, referring those people to health workers, then the situation can become serious before it gets addressed. So there are many options that can be, there are many options that can be followed, but it's just a matter of supporting, providing more training, more awareness to those communities, and just working with them in accompanying them in that approach of community-based case detection and referral.
Thanks, Charlie. I think that we really need to underscore what a unique contribution you have just made for the sleeping sickness community. Using simple tools borrowed from other diseases like TB to conduct a gap analysis in how communities can be involved in case detection. This is really novel for sleeping sickness programs, at least in my experience. And the second point that you made about involving alternative providers and church leaders in referrals of people that they see with early signs of the disease, that sounds to me a lot like the concept of communities of practice, which anthropologists from West Africa and America have tried to popularize in the field of skin-neglected tropical diseases, so Buruli ulcer and leprosy, where they work to create communities of practice, meaning people who are invested and interested in supporting case detection and programs and work together no matter what sort of category of expertise, formal or informal, traditional practitioner or patient, ex-patient, recognizing that many different types of people in a community can contribute to really important and fundamental issues that lots of these programs face. So thank you so much, Charlie. Salome or Anne, would you like to come into this conversation or offer a new perspective on engaging communities?
Yeah, it's very important that community have to be carried along in this roadmap, not as a top-down approach, but co-creation of solutions with the community.
Mm-hmm.
And in my interaction with the community, you get to realize that the community has a wealth of resources, Indigenous knowledge that can help bring about, help us to understand some things that we may be struggling with. We have the scientific knowledge. Of course, the Indigenous knowledge also is scientific, but sometimes we come with our knowledge and we impose it and we say, this is how we need to work. This is where we need to put this. This is where we need to put this. And sometimes the community will not put you off. They'll just tag along, but they know where the actual problem is. Mm-hmm. So to bring in the community, not as actors, but as active actors in this process. Sensitization, a lot of education, information to also help steer also their information towards the goal that we have. But also them being the ones who run the show and not us, because they're the ones on the ground. If well mobilized, they have a lot of power to be able to bring about a change. So empowering the community, holding their hands so that as we are engaged in the process of elimination, we don't just come in and go out, but provide all the required information they need, what they require to move along. But one of the things we also need to realize is that it takes time. So we need to be able to put the resources that are required to work with the community through this journey. Mm-hmm. That's what I would like to say, just in addition to what Charlie has said.
Thanks, Salome. And I think you're right. There is an important balance to strike in programs between acknowledging existing Indigenous knowledge as scientific, as you put it, or real and logical, and also using sensitization campaigns to steer people's knowledge towards the aims of the campaign. And I was wondering, because I know that you've worked a lot with the national program in Uganda with different populations. I wonder if you have any experiences to share about how you've struck that balance in both acknowledging existing knowledge and trying to steer knowledge or introduce new knowledge into popular discourses about the disease.
To answer that, I would like to draw upon experiences, not experience, but information or experiences that other researchers have done in the Ebola situation in West Africa.
Yeah.
There was the involvement of social scientists to help bridge the gap between the community and the health workers or the practitioners or the interventionists. And there was need to have dialogue with the community.
Mm-hmm.
You have this program, sit with the community to understand what are their perspectives, what are their cultural logics behind, for example, heart elimination. How do they view it? How do they perceive it? How do they view the plans we have? What is the middle ground or the compromise that we can reach? The community bringing in their expertise and their knowledge, the intervention programs bringing in their expertise and their knowledge. How do we reach a compromise that is suitable for the community for us to be able to move forward? So a lot of dialogue with the community, working within the community structures that are in existence, the village elders, the community gatekeepers, the religious leaders, and all the relevant leaders within each setup that is important towards influencing also the community towards adopting these interventions.
Thanks, Salome. That is another excellent example from a program outside of sleeping sickness that the sleeping sickness world could really benefit from. So instead of really thinking about information in terms of sensitization, one direction between program and communities, what we have learned from Ebola and from COVID today is that we should really be thinking in terms of dialogue. And there, every day we're hearing more and more about innovative ways that programs and social scientists have developed to facilitate these kinds of dialogues and really incorporate that into programming, acknowledging that communication is an ongoing and two-way process. I can see Anne nodding. I'm sure you have something else.
No, I was just going to kind of re-amplify your points. I mean, and the other to say, and I think Ebola really did clarify this, is that the message is incredibly important. The process of delivering that message is, almost 10 times more important, and even more than that, the kind of medium of the message, because you could see so much in those early days of the kind of urgency of Ebola, is that who was coming to convey the message could really, could make all the difference in terms of whether or not that kind of message was going to be taken forward. So, that requires, in terms of social scientific expertise, not only, Salome, you point about who are the right gatekeepers, who should we be speaking to, but also what is the history of those interactions between particular actors from the state, right? Is there a kind of, is it someone coming from the capital coming out, or is it coming from local organizations? And that can make a huge amount of difference just in terms of that dialogue and the tenor of that dialogue. So I remember, and this is a point also that's interesting thinking about elimination, is the kind of, when you're in a kind of a run to the end, right, a push to zero, there's a certain kind of time frame in which activities have to take place. And it usually gets a mark against social science because it is slow, it requires a lot of work. But again, I think Ebola is a really good example of this, is even in a really kind of outbreak emergency, it slows everything down not to have that time to really figure out how to do the process appropriately and who to talk to. And it might seem like not the priority, but actually sensitization can go terribly wrong without that kind of degree of nuance and information first. The other point I wanted to make, just, and it's such an important one that both Charlie and Salome were saying, is that, we have a sense of community engagement, that the community just kind of exists out there, that we just have to find this thing called the community, whether it's a village. But often, communities are incredibly complex. They can exist in neighborhoods. They can be a kind of spatial relationship. It can be a social one. It can be a religious one. And I think what's really interesting, and there's a nice question in the chat from Derek about being a kind of lab scientist and how that can support social science, is that depending on the activity, the kind of community you want to speak to is going to change. And And I was just thinking, I did some work in Dar es Salaam with larval control and source elimination for mosquitoes. And it was a lot of community-based surveillance, but initially the communities that were, spoken to were these community-based organizations, but those were not corresponding to the geography of the intervention, which were much more as a neighborhood level. So it required a lot of thinking of the project of how to almost reanimate these kind of 10-cell units and neighborhood associations, which were not immediately presenting themselves as the kind of voice of the community, but were the relevant kind of spatial scale to look for larval control and for breeding grounds. And I mention this just because I think the closer the conversation between what is the science, right? Like where were the kind of high risk breeding grounds? What was the kind of binomics of mosquitoes? And which kind of social actors are going to be most important for that, was key to the success of that endeavor. So I think we tend to think of these as separate activities, but I think the more conversations we can have about kind of, all right, we're looking at elimination, how does that shift areas of risk? Who are the relevant people that need to be engaged? I think can both enlighten the social science and also kind of speak back and help and support the kind of natural science work. A final point in this, and again, there's a question here about animals. It just reminded me, in the context of Lassa fever and Ebola, I was part of a project that was looking at spillover. And a lot of the sensitization materials focused on kind of hunting and hunters as a kind of key risk for point of contact for zoonotic transmission. But a kind of finer grain anthropological study showed how important children were in terms of kind of playing with animals, not necessarily going out as part of an older hunting activity, but just even on the kind of peri-domestic, semi, playing in the kind of the bush area. And the children became a kind of key point of conversation about where those transmission events were happening, but completely neglected in terms of sensitization campaigns. So just again, to say that to always ask anew, what community do we mean? And what does that look like? Who are the relevant actors, both the important ones in terms of respect and dialogue, but also where is the public health activity intervention going to be most salient to start from?
Thanks, Anne. All of those are fantastic points for us to think about. I think we often think about communities in sleeping sickness affected areas as being rural villages. But of course, sleeping sickness also occurs in towns and even the fringes of some cities. And certainly as you become more, as disease moves into more urban areas, the notion of community as well becomes much more complex. But even if you just think about a rural village, you don't have to move too far to really make the point that communities are complex, and it's more about, as you say, it's more than respect and dialogue. It's also about who are the most relevant groups to be thinking about and engaging. Charlie, I can see you've got your hand up.
Yes, I had just a point to add to community engagement, because usually we forget the context in which the sleeping sickness takes place. We talked about a neglected disease that affects rural poor people. And when we work on control activities, we focus on the medical aspect of the disease, and the livelihoods are not usually taken into account. So, and we have seen in the research that usually people don't participate in control activities because they give a priority to their livelihood activities. So in order to maximize or to get the community to engage really in a meaningful way, it will be also useful to have a component of livelihood activities combined to control activities. So as we don't like just working in a silo where we are just looking at the disease and forgetting in the context in which the disease is taking place. So when working, for instance, with community health workers who are usually volunteers, their time is can be used for control activities. But if we add to that some activities that they can do, for instance, they can, work on a project together that can, provide, I don't know, food or credit. Those kind of things can even boost the engagement or the interest in, getting involved in control activities. So as, we address the disease and all other needs that comes with the context in which people are living.
Thanks, Charlie. That's a really important point. And I know that from my knowledge of sleeping sickness programs, some of them do try and work with groups of fishermen who are often very exposed to Gambiense disease by the water, especially to bring active case detection activities to riversides, because it's so hard for those people to leave their livelihoods and come and screen. I've also seen examples of programs having specifically, different ways of working to engage soldiers by going into military barracks and getting different sorts of permissions to have people participate in active screening. And you raised some other really important ideas about working beyond just screening, but also drawing on the kinds of expertise and resources that are important, like food production, and how that can help sleeping sickness programs as well. Thanks. Salome.
Yeah, Charlie has also reminded me about the aspect of not everyone in the community is the same. And so we also need to consider aspects of gender equality and social inclusion, even as we engage in various intervention programs. But also importantly is the aspect of when we look at epidemic programs that deal with epidemics, handling epidemics, there's usually the aspect of the response, prevention, management, but it always stops there. It doesn't go about, it doesn't go to the aspect of reintegration or recovery for the communities who have been affected. And I think Charlie brings in a very important point, that recovery is very important after we have managed. Then how do we help the people who have had the disease to recover? And that would relate to their livelihoods, but also how do they reintegrate back into the community, given maybe the impacts the disease may have had on their livelihoods. So I think that's quite an important point. It's quite.
Thanks, Salome. And I know oh, you're muted. We can't hear you, Salome. Salome, can you turn on your microphone?
Sorry.
We didn't hear the last few things you were saying.
I was talking about the holistic management of the disease. I know there's a question, somebody has brought it about the animal. So the One Health approach needs to come in very strongly here in aspects of the multi-sectoral, the interdisciplinary connections, so that it's not just each team coming to do the human, then the animal comes in to do then the environment and the control of CCCAM. But can we have one message as different fields or disciplines, so that it's the same message that the community are hearing when an entomologist comes, when a social scientist comes, when a veterinary person comes? So that holistic approach is important. Yeah,
that's another really important concept for us to keep in mind. I think we often think about One Health as being something that's important for Rhodesiense sleeping sickness, where the reservoir is mainly in animals and humans are incidentally affected. But everything that you have said applies totally equally to Gambiense sleeping sickness. So thank you. Salome, you also mentioned gendered experiences. of sleeping sickness or the gendered needs of a community to engage with services. And I've heard you talk at our previous social science workshop in July last year about the gendered experience of caring for sleeping sickness patients, which is also really, really important to note, that it's not just patients who need this support, but their families as well. So thanks. We have a couple of questions that have come up from the audience related to our community engagement discussion. We have two questions on stigma, which I'll read out, and one for Anne on sensitization. So there's one, the first one on stigma is from Eric Schwegler. So it's regarding social stigma of recovered HAT patients. Can you please specify in which way these peoples are recognized as stigmatized? Because in Chagas and leishmaniasis, you have visible physical stigma, skin lesions. Is there a similar thing for HAT, or is this the mere fact that these people once had been infected, which leads to stigmatization? So what are the visual signs that could contribute to stigma in sleeping sickness, or is it something else? Then the other question about stigma comes from Tim Jesudason. What is the association between reducing prevalence, community knowledge, and stigma? For example, as prevalence of HAT declines and younger generations have lower levels of knowledge about the disease, is this likely to lead to increased stigmatization of those remaining affected? What implications should this have for programs and settings reaching elimination targets? So maybe let's deal with those two questions on stigma first, and then we can go to the question for Anne on sensitization. Does anyone want to hazard a response to the issue of stigma in sleeping sickness, and particularly as the disease declines, whether it gets worse?
Yeah, I can start. Yeah, for the case of the sleeping sickness, stigma is quite insidious because, yeah, of course, when someone is presenting the symptoms of the second phase, everyone in the community knows that that person is, has a sleeping sickness, and that person has lost their mind and it's no longer a normal person. So that creates that stigma. However, that's a representation that people have about the sleeping sickness is not only applied to the symptoms of the second phases. Even just being diagnosed with a sleeping sickness without showing any symptoms, already they associate that, all those symptoms about, someone who has lost their mind, someone has become crazy, someone who can't, function normally, even if when you are not showing any symptoms. So that has been shared by many people when we're doing the research. When you ask them why people don't want to participate to screening, the answer is usually people will, make fun of me if they found that I have sleeping sickness, even when you don't have any symptom. So even when someone has been treated and has recovered, there is always that, feeling or that perception within the community that that person has never recovered completely. Whatever, even in discussions, they will just, in a group, for instance, when someone who has, suffered from the sleeping sickness is speaking, they will just, dismiss whatever they are saying that, maybe your mind is not normal yet. So it's there, you live with it for your whole life, just because you've been affected by the sleeping sickness. And yeah, even when we're talking about gender issues, the recent study that we just conducted, evaluating the communication strategy, when people, heard about the new treatments that have been developed, people were so happy because they said, with these new techniques, we think that women, for instance, or girls, if they can be treated early enough, they can still get married, because before, just being associated with a sleeping sickness, your chances of getting married are almost zero. And that's, strangely, in doing this research, I came across some family experience. Apparently in my family, there have been a case of a sleeping sickness, and someone who, one of my my uncle's wife had that disease, and the marriage had to end because of that. So it's quite serious, the stigma issue. And talking about the second question about the decline in the prevalence and the stigma, that's quite a complex question, because the stigma comes with the knowledge of the disease. So when young people don't know much of the disease, I don't think that the stigma will be really as pronounced as in a context where everyone knows what a sleeping sickness means. But I don't know, maybe the decrease in knowledge, the main issue will be maybe just difficulty to identify someone who has the sickness and the delay in seeking medical care. But in terms of stigma, I don't know whether, the decline in prevalence will maybe also will affect the decline in stigma. I don't know. That's the way I think,
Yeah, the second part is, I agree, really hard to answer and theorize about. Did anyone else want to jump in and give some observations of their experience of trying to understand stigma and sleeping sickness, because it is a tricky concept?
What I can add is the stigma is about the knowledge of the disease, as Charlie has said, and also the perceptions that community have about the disease, maybe because of some of the experiences with the past sleeping sickness patients. For example, in some communities where we were working, sleeping sickness is associated with the reduced virality in men. So you'll find communities telling you, the men telling you, we don't want to be tested because somebody who is tested and now is found with sleeping sickness will lose his manhood. And that was quite a key thing across different communities about that. And so that stigmatization comes in, and you find in families, some families, just like Charlie has said, even in Kenya, we had families where they broke up when the man, one of the spouses was sick. You found that they went to hospital, they came back, they found the other partner has run away from the home. So there's that stigma attached to it because of the experiences. Some is because of the experiences that people have gone through. Some is because of the perceptions they have of what the disease will do to the person. And some is as a result of the impacts of the disease on those who are affected. So that brings in that aspect of stigma.
Yeah, I think it's also probably quite important to note that people's experience and sense making around stigma really changes along their experience with the disease. So I know I completely agree with Charlie that one of the most stigmatizing aspects or symptoms of sleeping sickness is the association with mental confusion, as well as reproduction, as Salome said. And I remember talking to some older women who were newly diagnosed at the end of stage 1. And they were trying to make sense of what was happening in their body to know how the disease was affecting potentially their mind. And this one woman in her 50s was laughing as she was recounting this story about how she knew that she might have sleeping sickness because when she came out of the shower, the public shower, she'd forgotten to put her clothes on. And she was thinking, I don't know if it's old age or if this was an early sign to suggest, oh no, I think all the other things that you're experiencing, maybe this all makes sense as sleeping sickness. And that's why I went to get a test. So people can kind of learn from discourses about stigma and incorporate them in productive ways that lead to treatment. I can tell another story of following a patient for quite a long time after his treatment, as you have done, Charlie, and I think also Salome as well. I think it is really important to continue following people after their treatment to understand what's happening in their lives. And this was a man who continued to have very violent behavior. And there was a lot of sense making that people around him did, trying to decide whether his violence was due to the long-lasting effects of sleeping sickness, which could be a form of stigma. But some of those people ultimately said, no, he's been treated. He doesn't have sleeping sickness. It's actually because he's a cattle raider and a criminal. And so it's this other aspect of his personality and not sleeping sickness that he suffered from, even if there were some of these long-lasting effects on his body and mind from the disease. And as we all know, stigma is an intersectional phenomenon. So lots of different parts of a person's identity and how they're perceived by communities can really contribute to the way that they experience stigma. Is there anything that you wanted to add, Anne, on stigma? No.
No, I was just looking at that question about how sensitization can go wrong. No, I mean, there's some very, numerous examples, I'm sure. I mean, I think one of the more, just thinking back, glaring ones from Ebola, of course, was, the death, actually the murder of a sensitization team when they came to WOMI and it was one of those cases that I think initially gets written up and understood as kind of cultural resistance, kind of understood as kind of, a clash of, cultural understanding and people not understanding the disease. When I think a lot of rich anthropological work has pointed to the kind of political context in which you have a delegation coming to a region to talk about a disease in the context of a lot of other issues that the community would want to address, particularly the delay of elections, the feelings of, other kinds of wrongs, and where Ebola comes to kind of silence and occupy that space and begin to be seen as actually as a kind of nefarious excuse for further inequities. And, I think just, again, looking back at kind of who is giving the message, like in what kinds of political contexts in which that happens is huge. I mean, you can talk about Ebola, you can also talk about vaccination outreach in the US, right? In terms of who is delivering the message and how politicized those conversations can become and how resistant people can be to taking up vaccination when they see it as part of another political party. And I know there's been a lot of work, particularly in the US, of trying to kind of reorient the message of vaccination to people's local providers, to people who they trust, and the importance of communication coming from networks of trust that aren't seen, that work against the kind of sense of things being politicized. So again, I think we tend to think of sensitization as just this conveying of technical knowledge. And that is a huge part, is democratizing information, providing information to people. But as this panel kind of has said much more eloquently than I am right now, the importance of dialogue and realizing, again, that who is delivering the message and the broader political context in which those messages are being conveyed can make all the difference in terms of whether or not that message is taken up.
Thanks, Anne. Yeah, I think there's a couple more comments that kind of have bounced off of the discussions we've had. I'm sorry, I don't know how to pronounce this. Who am I looking at? The questions are moving around on my screen, apologies. Someone appreciated the One Health comment that Salome made. And then Karina has said that it could be valuable to add sleeping sickness and other diseases into school curriculums so children and young people are more informed and can contribute to the idea of community-supported elimination and recognize early symptoms and to decrease stigma. So thank you. And Christiane Burry, who has worked on sleeping sickness medications through clinical trials for the last few decades, he has an opinion on stigma and believes that the advances in treatment will reduce stigma because the effects, the treatments are easier to tolerate, they're better, they result in less deaths, and that makes a lot of sense too, Christian. So thank you for that comment. I think we have addressed most of the questions that we can in this. So I'd like to move on to the third question that I introduced, which was the concept of healthcare workers as resources. What is your perspective on how we should view health workers as resources, and as well as the needs that they may have in sleeping sickness elimination programs? So we've talked a little bit about the labor of health workers already, but does anyone have anything to add about how we should view health workers in our sleeping sickness elimination programs going forward?
Let me just start by sharing maybe a story that I had about health workers in South Sudan during the political situation that was there. That the health workers that were there, the health workers are committed to what they do. And sometimes even in situations where the environment may not be conducive, they still push on to do what they need to do. And I bring this out because I recognize the resilience.
Salome has frozen, but I think she's raising. Salome,
hello?
Hi, you're freezing. What we heard is you've made a point that health workers who work on sleeping sickness should be viewed as committed and resilient.
Yes. Can you hear me now?
Yes. Yeah, maybe you could expand on that.
So what I mean is that I'm talking about the health workers who had been trained in sleeping sickness in South Sudan, that they would move with their equipment and still do testing even out of the health facility to be able to help the community. So I think it's a key resource. Health workers are a key resource that need to be supported. And now in the aspect of elimination, constant sensitization of the health workers is required, given that they're working in a system where there's high turnaround of health workers. You find a health worker today has been trained on sleeping sickness, tomorrow you find they've been posted to another area. So you find you keep training. So one of the things we realized was that there's need for consistent refresher trainings on diagnosis of HAT within the setups, but also that this needs to be piggybacked on other health problems within that setup, so that it's not just one disease, but they handle other things, but they also have the knowledge about how to deal with sleeping sickness. They're also a community on their own. And so it's important also to understand their perspectives, to understand their perceptions about the disease, because that also influences how they deal with the disease and how they also provide information to the community about the same. Over to you.
Thanks, Salome. You're absolutely right. Health workers are a community to themselves, and they play a pivotal role in communication to communities, and they are used by programs in some ways actively, in some ways in very indirect ways, to pass on sort of institutionalized messages about sleeping sickness. And they also bring their own experience to interpret a lot of those messages in the ways that they talk about sleeping sickness and engage with patients and their informational needs as well as their care needs. So all really good points. Charlie or Anne, did you have anything that you wanted to add?
Yeah, what I can add to what Salome has just mentioned, indeed, the health workers form their own community. And the perception that the community has towards these health workers is quite interesting, because I found in my research that you have two groups of health workers. You have those who deal directly with the sleeping sickness, the members of the mobile units and health workers at treatment centers, and those who work in local health centers. So those who are involved directly in the treatment or in the screening are very trusted by communities. Communities think that these people are really specialized in the sleeping sickness. They know what they need to do. They are well equipped and they trust them. Whereas the local health workers who work in the health centers and perceive not to have the capacity or the ability to handle the sleeping sickness. So they are not treated, they are not trusted at this point by many local community members. So I think at this point is we need to get the community to start trusting also the other health workers, because we are in a process of integrating the health, the treatment of the sleeping sickness in the normal health system. So with the new treatments, which are much easier to administer with the new screening approach, all those things, we need to work on ensuring that the community members trust even the new treatments. Because some of the communities will tell you, a drug that is just given, orally, it's not strong enough. And if it's someone I know from this local community who's, giving me this treatment, I'm not sure that, they are really treating the sleeping sickness, because we know that this sickness is always treated at this center with these specialists, etc. So we need to work maybe we can get the specialized team to work with local health providers to mentor them and to get to create that environment where the community will see them as a one group, so as they can trust those who are the local provider and those they are used to see working on the sleeping sickness, so as they can both work together in in the process of the elimination. So that's what I can say about this.
Charlie, you raised such an important point about where we're going in sleeping sickness towards oral medicines. So, what Salome said, where we have to be thinking about constant sensitization and making educational opportunities available for new health workers coming in, and using, and then as you said, using the experts to mentor, that we need to think not only about frontline health workers' confidence in being able to deliver sleeping sickness activities. So can I recognize the signs and symptoms and make a good referral for a test? And do I feel confident managing treatment? We also need to think about communities' perceptions of those frontline health workers, which are so key to elimination through this modality of health service integration. And I think you're totally right that that people's endemic communities' perceptions of oral drugs. Currently there are, I think, 10 drugs that people take for dexamethasone, but we're moving to a single drug. And so what will people think about those drugs? And behind that, what do they think about the people delivering the drugs? So it's really similar to the messages that Anne was talking about in terms of sensitization. The messenger is important in delivering the message, and the health workers who deliver the treatments. We need to think about trust building around that as well. And Charlie, you mentioned that we should be using the specialists to mentor these health workers and do what we can to make sure that this mentorship is very visible, perhaps, to communities, so that they see that the specialists trust the frontline health workers to do this work, and to try and, I guess, share some of that trust capital, if you will, in the programs. Thank you. And did you want to add anything?
I just wanted to come back, and I think it's quite an important, and it really resonates, this kind of how to think in the context of elimination, like how to bring these two kind of the specialists into the kind of local provision of services. And I mean, also from the perspective of, your point, Salome, about, kind of rapid turnover. I mean, what are the career opportunities for those kind of specialisms as the disease disappears, right? I mean, people, go into health work with their own sets of career aspirations and goals, and thinking about kind of what is the future of that work for them and how that can be structured. I wanted to bring something else up though, Jen, and I actually wanted to throw it to you too. I know you've been doing a lot of moderation, but in terms of, that really important point about how we see, how do people feel about the drugs, right? And how do they perceive the treatment, but also about the kind of diagnostic process and kind of the introduction of rapid diagnostic technologies. Is this something that has the potential to empower local communities to be seen as people capable of providing these kind of proliferation of tools, or are there, constraints to that process, or what would be important in kind of the rollout of those diagnostic technologies? And I know, Jen, you've worked on this too, and I just wondered if you wanted not to steal your chair point, but just to give you the space to reflect on that as well.
Yeah, it's an interesting point. In the panel, in the roundtable yesterday, people were talking about the idea of a test and treat strategy, where if oral drugs are safe enough and easy enough to give out, then we can just treat on the basis of a positive rapid diagnostic test and not have to refer people through the laborious process of confirmation, with the understanding that we would be over-treating potentially a lot of false positives. I'm sure there's people in the audience who are going to disagree with some of the things or correct me, which feel free to do that in the Q&A. But yeah, your question is about how do we think about communities, about empowering communities to use those rapid diagnostic tests to have more control in the process of accessing treatment, because ultimately that is what people are interested in. It's not just about testing to know what's in your body, it's about how do I cure myself of this potentially stigmatizing disease. And in my previous work in South Sudan, it was very clear to me the role that that communities, in particular certain patient populations, had in trying to actively gain access to tests and diagnostics. So there was a huge proportion of the people who were tested who were actively asking for the tests themselves. They weren't referred by health workers. And this really reflects the desire, I think, for people to control their own access to sleeping sickness tests and treatments. And it's really important that programs recognize this and take advantage of it. If people want to test, and we're always saying people aren't showing up to our screening programs, we have to do everything that we can to respond to this demand for sleeping sickness tests when people have treatments. I don't know if you have anything else that you wanted to add, Anne, about that, but I'm sure we could go further.
Yeah, no, I mean, and I think your comments have highlighted that. I mean, I think understanding the kind of limitations or what the diagnostic allows you to do. I mean, we see them as a kind of panacea for a whole kind of clinical process, but still there is trust required. Still there is kind of capacities of the people holding and using the tests and communicating the tests. So I think, it's interesting to kind of how social science can come along with these kind of technological innovations in order to kind of have them do what they can do, right? Which is exactly right, giving, extending the kind of power of expertise and diagnosis, but, realizing that that's going to come with these trade-offs around kind of what is the accuracy of the diagnosis.
Mm-hmm, mm-hmm. And not only thinking of health workers as the extension of programs, but also gatekeepers. And health workers can provide a block to patients who want to access tests or who don't understand what health workers are meaning when they say you need to go do more tests at another place because this result is positive, but it might be negative. Those are really complex issues that programs need to grapple with. And one solution is to try and empower more people at the patient side to take control of their ability to test. It's imperfect, of course, but it's one side of it. Salome or Charlie, did you have anything else that you wanted to add on this topic of how we view health workers and their role in elimination programs?
I think that at this point, the elimination program maybe brings some concerns among the health workers, who have been working on this disease for years. And maybe elimination means also the end of, becoming jobless or losing the livelihood. So we need also to think about them as just people, not just health workers. They're people, they have families. So if there is a way to integrate them or convert their skills to another disease, because some of these skills are transferable. Of course, they have specialized on specific case of sleeping sickness, but I'm sure that it's not only the sleeping sickness, there are other skills that come with it that can be used for other diseases, and that can be really valuable. So I think there must be a way to take advantage of what they have gained over the years, all their experience, and use them for other diseases, and also at the same time addressing their needs as people. And yeah, so that's what I can say.
And that's a very generous way of putting it. Often in the sleeping sickness world, we think, no, we've got to keep our human resources, maintain their expertise, and train other people. And you're saying, let's not forget that what they have can be useful to other health programs, and they can build their careers in other ways too. So another really important point.
Also, just to chime in, we have health workers who have been there for quite a long time, but maybe retired. And I think this can come in handy, especially when we're having this mentor program, that they can also be part of the mentors for the current health workers in the facilities, because they have a lot of experience, they have a lot of institutional memory in some of those health facilities. And so they can be brought in as also just mentors for the current health workers within the system. Yeah.
I think that's totally right. And I think actually the NBI has been quite good at retaining retired health workers to participate in the clinical trials, if I'm not mistaken, in some of those locations. And also to sit on steering committees and chairs and contribute to these kinds of knowledge sharing roundtable discussions as well. We have another question about whether health workers can intervene at schools from Sandra Rembry. Does anyone have experience of schools being involved in sleeping sickness campaigns? I think in South Sudan, I've seen mass campaigns visit schools. So I think that's traditionally been one of the many targets to ensure engagement in active screening. I think that teachers have also historically been quite important in identifying students that could have sleeping sickness based on their behavior in class. Sleeping at their desk is a big one that emerges in the stories that I've heard.
I can also add that in Kenya, we used school children. The time we had a lot of cases of sleeping sickness, we used school children by sensitizing them, and then they would pass the information on to their families. And so they also are a critical point in terms of just knowledge and awareness creation in the community. So they should also be included through various ways, maybe through the brochures that are friendly to the children. I know WHO developed some brochures some time back for the children, but also just maybe presentation of songs or skits or theater that can promote sensitization in the community. Over to you.
Thanks, Salome. Yeah, those are really good points to build on what others have already said. Even in Charlie's presentation, she talked about needing community engagement to be really innovative because it's harder. Communities are not feeling as at risk of sleeping sickness. So we need to be more creative in the way we circulate information, particularly to young people. And also Anne's point about children being potentially relevant groups to target in disease control programs.
Yeah, I mean, I was just thinking, I mean, particularly when it comes to kind of identifying spaces of risk, I was thinking, you know, with the tiny targets, kind of repellency around tsetse flies. Like when I was involved in some work in Rio on a kind of release program, and they did a lot of work in schools, and they actually had the children, or kind of, you know, school age, take pictures of dangerous areas in their landscape. And it could be, I mean, it wasn't necessarily directly associated with mosquitoes, but it was a way of kind of gathering awareness of how people understand risk more broadly as a problem, both of disease control, but also, of course, of kind of violence in these areas. And I think it was enormously helpful for the program because it really, you know, captured student engagement and kind of thinking about public health more broadly, but also helped identify other kind of spaces of breeding grounds. And I think, you know, again, the nice thing about schools is it is a space of learning. And I think you can be quite comprehensive about how, you know, what kind of messages you're engaging, and learn from the students about, you know, what bigger issues might be, you know, shaping how they're thinking about public health, or they're thinking about kind of risk in their environment. So, you know, it's, again, I think it's this tension that we've been talking about since the beginning between a kind of very targeted, almost silo approach to a disease problem, and how I think as social scientists, we can begin to kind of see the connections with other, you know, issues and problems, and how those kind of wider networks can actually help bring back to what might be the targeted elimination, more narrow goal in the end.
I can also add that, yeah, children should be now the main focus because of, you know, their lack of experience of this disease. So to make sure that the collective memory, you know, lives on, we need really to have specific, child-specific approach for sensitization, so as they get to understand and to know about this disease. And the health workers are very good at doing this. They have seen, they can tell, you know, the history, their experience, they can share the experience with children. And I think that storytelling is quite captivating, and children can get to know how serious the disease was and what has been done to eliminate it, and what they should be doing to make sure that it doesn't come back. So I think there is really a scope for health workers to get involved in the education system and to deliver those messages.
If I may add?
Yes.
So in some places we have health workers going to do public health sensitization in communities, and even in schools in relation to public health information, for example, wash-related activities, teaching children how to wash their hands, and, you know, how to just ensure there's hygiene. So maybe one of the aspects we could also do as we go towards the elimination is layering on sleeping sickness or human African trypanosomiasis information into these public health interventions by health workers in the schools, so that we can give already what is existing.
Thanks, Salome, and thanks, Charlie. I think you're absolutely right. Health workers, especially the specialists in sleeping sickness, are fantastic storytellers. And schools are, as Anne said, really these amazing spaces of learning where we don't need to think about information being communicated through a megaphone in one direction under the mango tree. They can be so much, education can be so much more exploratory as it relates to sleeping sickness. And I think that could be a huge new direction for sleeping sickness programs in an elimination context. We've had some more questions come in at the beginning, before we even started the webinar, but we've been going on for quite a long time. So I think I'd like to just end by returning to one of the key questions of the purpose of these 3 days, which is about the gaps in research needs that need to be addressed to contribute to elimination. I think collectively we have come up with a huge amount of new spaces of innovation that sleeping sickness programs could go into. I won't enumerate them all because we do have somebody taking notes. But if there's anything that any of you would like to add that we haven't already discussed about research gaps or needs that are specific to elimination, now is your chance. Okay.
I have a quick thought and just an extra comment. And it was raised in the questions just about if we think about kind of more cryptic contexts of transmission about, just broader sets of kind of, I guess, species entanglement, right? Or kind of places of risk. And, again, as I think, going to zero means looking at ever more kind of granularity at points of potential contact. And I think maybe opening up kind of how we've thought about, what is the sensitization messages that we're giving? How has that changed in terms of elimination? Who are the actors and doing some of the amazing, picking up on this work about kind of, mapping of actors who might be, we should outreach, whether it's children, whether it's kind of different points and spaces of concern there. I also, it's interesting. That point, Charlie, you were saying just about kind of storytelling. And I think it is an interesting moment to kind of rehearse and look back at the history of control, right? And, how do we tell that history and where we are and what from other kind of big elimination programs, whether it's kind of smallpox or malaria, how at this kind of pivotal moment have communities, where have been the sticking points have come into work. So I'd love to see some kind of comparative, analysis about kind of community engagement in the context of elimination that looks precisely across different diseases. I think that's a really important point of reflection.
Would make a great master's project as well. Thanks. PhD for all the students that are listening. Anything else from Charlie? Yeah, go ahead.
Yeah, I think it's time now that we try some approaches now that there's no really sense of urgency, like the disease is happening and people need to be saved urgently. It's time, we have now time to kind of pause a little bit and do more social aspects compared to the medical ones, because there is a lot of development in the medical sector with drugs and testing and everything. But on the social aspect, especially the psychosocial support of patient or previous patient, because they're still living with all the issues that they resulted from the sickness. So it's time maybe to try something in that area, to experiment a little bit and see how it works. And later on trying to expand whatever the findings that will get to other areas. So I think this is one of the aspects I would like to see research done.
Yeah, you're absolutely right. We do have the time now, Charlie, and there's no, just because elimination is near, doesn't mean that we should stop doing research. Actually, there is a huge need to see how social behaviors are evolving, how ideas are evolving, and how that affects real experiences for patients, both in terms of their access to life-saving treatments, but also their lives, their livelihoods, and their social relations after disease. So thanks for making that broad point. Salome, anything to end with from you?
Maybe one of the things that the Heart Fraternity can think about that I've seen in other, maybe borrowing from the agricultural field, where they've been developed digital technologies that help provide information to farmers, and farmers can also ask questions through the digital or mobile phones, and they get information that can help them make informed decisions about their farming behavior. So maybe it's time that also within this human-animal disease, that the need to come up with a digital platform that can help convey information, help farmers, help also the community pass information back, a two-way traffic. Maybe it's time to explore that platform. Yeah,
you're absolutely right. Most of the digital platforms that we now use in sleeping sickness are to extract surveillance information to go up to national programs to report on elimination progress. But you've just pointed out that plenty of people have a need for sleeping sickness specific information in their life. And digital platforms could be really important for that. So thank you, Salome. Okay, I think let's end it here. And everyone in the audience, we can't hear you, but I'm sure you can join me in a round of applause for our incredible panelists. Thanks. Olaf, I don't know if you had anything final to say, or Catherine Forbes. We can't hear you, Olaf.
That it has been so rich that I don't know where to start.
You're muted again.
Yes, okay. So I took some notes, and it has been a nicely overview for very different aspects. I mean, the subject is infinite, and we have just scratched the surface, but we need. I mean, for instance, when discussing about communication and communication material, what came very, very clear is that we need to have a two-way relationship, not only just dropping posters or information into the people and then just go away. We need to hear, we need to listen, and we need to get information from the people that has direct physical contact with the disease, with the problems of the disease, and with the people suffering from the disease. Something that is not evident from what you discussed is the issue of stigma that was really very, very interesting and very, very deeply analyzed. But as one of the questions said, you feel about stigma more understanding when you see something physical, external in the patient. So for us, we understand if someone has physical issues, you can understand the concept of stigma, or with this kind of diseases like HIV. Here, it's difficult to understand why is this stigma, but you raised very, very nicely a couple of very important issues. One is the mind loss. You didn't talk about witchcraft, which is something that is very present, but the mind loss is something that goes on even after you recover your mind. And we have seen that in many cases, and this is something that requires support and requires understanding and requires communication at the community level. Another very important element of the stigma is the situation of women. And you raise it very nicely, because on the one hand, you see that girls, young women cannot perhaps marry because they feel that having passed the disease will make them infertile. And this is one element. But the other element, which is very terrible, and we have seen that very much in our clinical trials, is when a married woman is expelled from home. So we are not talking just about divorce in the sense, neutral sense. Is someone that is expelled and left without any property because of the sleeping sickness. So there is no patients simply boom, out, and there is no way back, which is really a pity, knowing that this disease can be totally cured. So this kind of issues need to be transferred into the communication activities. Something that I enjoyed very much is when you discussed about community engagement. The concept of communities of practice, and how we need to tackle not only a community in the sense of something physical or geographically limited, a neighborhood or a village, but also the community of people involved in the same kind of beliefs or practices or professional activities. You have been talking all the time through that, referring to fishermen, or referring to religious, or referring to health workers. And the health workers, which was the three big subject of the discussion, has some very important elements, and I like very much the comment about the difference of perception of the health workers, the had experience health workers coming from the vertical program that they are targeting this, and the trust for them, and the lack of trust for the regular primary healthcare workers, which are perceived like not knowing anything. And I think this is a pity, and this is a pity related with the system, because we have been trying to make it effective or efficient. We have been isolating sleeping sickness from the rest of the diseases. In our internal discussions, when we work about when we talk about the development of new drugs, we say that one of the elements we wish to get is to transform sleeping sickness into a normal disease. And transforming it into a normal disease means that it should become something within the primary healthcare, not anymore vertical. But then you brought something really important too, which is the element of loss of capacity, because you cannot just say, okay, let's integrate, let's throw the responsibility towards the primary healthcare system, and let's forget the vertical system. If you do that, this will be certainly a catastrophe. So what we need to do is to find out the way to integrate not the activity itself, but the mind setting of the vertical program into something that is less executive and more orientative and more networking, supporting the peripheral health system, which is composed of the health workers that are close to the people. Because also Anne commented at a certain moment that sometimes the message is not the most important thing, is the person who brings the message, because the person who brings the message will make the recipient of the message trust or not the content of the message. So those elements, of course, there have been a million other, and we will take consideration the comments you did about the gaps in research, so that tomorrow we insist a bit more in what remains to be done from the research perspective. And there are many other things. I mean, my notes are so rich. I think perhaps I will see again the video of this meeting, so that I can get even more fine tuning of the conversation you had. I want to thank you very, very much on the discussion you had. Jennifer, I want to congratulate you on how did you facilitate so easily an active participation by the three speakers. And of course, Anne, Charlie, and Salome, I admire you. That's all. It's fantastic what you did, what you do, and what we perhaps may do in the future together. Thank you very much.